evening. It's Dr. John Bennett of internetmedicine.com website. We have the pleasure of having Rick Novak, anesthesiologist from Stanford, who I did some webcasts with a long time ago when we were using Google Hangouts, and now it's changed to Zoom. And I'm glad to re-establish ties with Rick. And Rick will tell you what he's going to talk about. And it's good to see you, Rick, and it's all yours.
Thank you, John. The topic today is anesthesiology in the time of COVID. I chose those words because back in the 1980s, there was a very popular novel called Love in the Time of Cholera. It was written by Nobel Prize winner Gabriel Garcia Marquez. I read it and enjoyed it quite a bit. They made a movie out of it. And it was an abstraction because living at a time of a plague or a horrible pandemic was something none of us thought we'd ever have to live through, but now we are. So the outline for today is like this. This is primarily directed toward medical professionals, although lay people will be able to understand most of the information. The anesthesia at the time of COVID is very fluid. What I tell you today may be different 2 days from now when more information comes out. And certainly in a month it may be very, very different. But as of April 17th, 2020, this is where we're at. The outline will be like this. First, I'm going to talk about more acute care anesthesia in terms of ICU care and intubating duties. Secondly, we're going to talk about anesthesia machines as being used as ventilators outside of usual anesthesia practice. We're going to talk about the rationing of ventilator care and the SOFA score. We're going to talk about the San Francisco Bay Area where I live and work versus New York City and the comparison and contrast. We're going to talk about underemployed anesthesiologists at this time, and we're going to talk about what reopening anesthesiology is going to look like when the surge is finished. I'll start off by telling you that anesthesiology is in the United States right now, very bimodal. We have anesthesiologists working very hard in acute care settings, and they are taking care of COVID patients. They have very dangerous jobs. And you have many, many anesthesiologists who are doing nothing because elective surgery in the United States has been canceled for some time now. We're going to go to some slides at this point. That's my academic title, the date today. So first off, in terms of acute care anesthesiology, this is what I would consider the most famous anesthesiologist in the world right now. His name is Corey DeBerg. You probably have never heard of him, but he's famous. He was the subject of a Washington Post article on April 5th, 2020. He's on the intubating team at his University Hospital in Chicago, Illinois. And he intubates patient after patient during his shifts, and he wears the protective equipment that you see him in there. And he said right up front, my job, he says, is like you're right next to the nuclear reactor. So his face is right in there where, you know, oral pharynxes are full of the virus, and it's very dangerous. And he said some very interesting things. He said that he was often the last person to talk to many of these patients, and he was the last person many of them would see, because after they're intubated, then they're placed on a general anesthetic sedation, and 80% of those patients die. So it's a dire thing. The American Society of Anesthesiologists has held 3 Zoom town halls in the last month, including one last night. So that's where I'm getting a lot of my up-to-date information from around the country. What the specialists focused on last night was the acute care in the ICU. And the predominant things they said was there was a lot of lung disease, which we know about. There's a lot of encephalopathy that requires a deep sedation to keep patients on the ventilators from being very difficult. There's a lot of coagulopathy and sometimes bleeding. And there's a significant shortage of the medications they need to sedate the patients. There's a shortage of fentanyl, propofol, muscle relaxants, and the drugs that they need to sedate the ICU patients. The next slide shows, this is from Wuhan, China, but this is an anesthesiologist intubating a COVID patient. You can see they're wearing the hood and all the protective gear, using a video laryngoscope. That's recommended because you can be further from the patient's airway when you're intubating using that than if you use a traditional laryngoscope. And the next one is a picture I included because this is a topic called proning. Proning is when the patient is placed in the prone position, you can see this patient is on an endotracheal tube, is on a ventilator. And then for ARDS, which is adult respiratory distress syndrome, this has often been a helpful ICU management. They're finding that with COVID patients, it's not necessarily that valuable. Some patients it helps, many patients it doesn't. They describe it as a very labor-intensive move to turn the patient into prone position, because it takes several individuals to turn the patient over, and every one of them has to be wearing the PPE, and every one of them is, as we said earlier, is right next to the nuclear reactor. There was an interesting article in the New York Times this week. It was dated the 5th of April. Well, it was actually last week, because today's the 17th. So 2 weeks ago, what doctors on the front lines wished they'd known a month ago. And what they had to say dealt with the topic of prone positioning. And what they were doing is they found that if they had patients who had low oxygen saturations, as low as 50s and 60 oxygen saturations, if they put them on nasal oxygen and turned the patient into the prone position without intubating them, that their oxygen saturation would improve. Now, of course, this isn't a randomized study. It's not a published study, but in these times, things are changing so quickly that we don't have data. We don't have time for peer review, but this is what they were finding. They had anecdotal reports of people coming in with oxygen saturations in the 50s, turning them prone with oxygen nasally, and then the saturation going up to 92, so avoiding intubation. These are some of the notes that they were included on the online version of the New York Times. They said that, if you look where the arrows down here, they said that proning non-intubated patients with COVID enables them to live longer, not be ventilated. Up here, every mammal that runs really fast runs prone. That's what they had to say. This data was concluded with the article as well. The net change in intubations in New York City over a period of time. Now, this font is very small, and I apologize, but this is 3/17, so it's mid-March, and this is 4/12, which was earlier this week. You can see the rate of intubations has dropped off, and some of this has been due to the prone awake oxygenation. And this statement here is very true. The intubated patients with the COVID lung disease are doing very poorly. An 80% mortality with all the resources and time putting into them is certainly an investment that could be questioned. What about the need for extra ventilators? Now, in New York City, they had periods over the last 2 weeks where they had, if you have N ventilators and you have N plus 2, 3, 4, 10 patients who need ventilators, what are you going to do? So one of the topics was, can you use an anesthesia machine? And the answer is yes. This is a picture of an anesthesia machine. The cursor where I'm circling here, this is the part of the machine where the ventilator bellows is. It hooks up to 2 hoses. And yes, you can ventilate a COVID patient. Over the years, we have taken patients from the ICU and brought them to the operating room and placed them on anesthesia machine ventilators when they needed surgical care. Maybe it was a laparotomy, maybe it was a tracheostomy, but anesthesia machine ventilators can use. We had anecdotal information that at a university hospital in New York City, a week or 2 ago, that 42 operating rooms were being used as ICUs with the anesthesia machines being used as ventilators. So that certainly can happen. Now, who gets a ventilator and who doesn't if we need to ration medical care? So there is a publication by a Chinese physician named Zhao, and it came out in Lancet. It was in late March of 2020. It was a retrospective study where they looked at the death rates of people admitted to their ICUs and what correlated with better or worse prognosis. The odds of dying in the hospital increase with these things: increasing age, which we're all aware of, a D-dimer level, which is elevated. Now, a D-dimer level means that the patient is having more coagulation or hypercoagulability than is desirable. And something here called a higher SOFA score. So in America right now, if you said SOFA score and coronavirus, you think of someone lying on the sofa watching Netflix and scoring how many hours it's been that he's been doing that. But in truth, the SOFA score is something else. It is SOFA stands for Sequential Organ Failure Assessment, and it deals with the main organ systems in the body. First, this is just a graph when we're talking about increasing age and worse mortality. This has been well known, has been distributed for several weeks now. We know that if you're in your 80s, the death rate could be around 15%. If you're younger, less. This is the SOFA score slide. So on the left of this table, on the left of this table, you've got this main systems: the lungs, respiratory, coagulation, liver, cardiovascular. CNS stands for central nervous system, and renal. So as you are doing worse with your ICU patients doing worse in each of these systems, you get more points. So respiratory, if your PO2 is very low, you get a very high respiratory score. Cardiovascular, if you're on dopamine, epinephrine, or norepinephrine at high rates of infusion, you get more points. For CNS, if the Glasgow Coma score is low, you get more points. And what they found at the Wuhan retrospective study is, along with increasing age and being hypercoagulable, if you have many points on this scale, your odds of dying are worse. The numbers that they published, where they looked at 191 patients that were admitted to their ICU. Of those, 137 were discharged alive, 54 died in the hospital. So the number dying, we think that the mortality rate is somewhere around 2 or 3%, but in that initial Wuhan study, the mortality was close to 25%. For the next topic, I want to look at the geographic differences in what's going on in my specialty. I live in San Mateo County, pardon me, and I work in Santa Clara County. So where the cursor is here, this is where Stanford University is. Santa Clara County has a population of nearly 2 million people. I follow the Stanford Internal Medicine Grand Rounds via Zoom, which is going on once a week. And these are the sort of numbers that they gave us. On April 1st, 2 weeks ago, Stanford University Hospital, which is the major trauma center and academic hospital for this part of the Bay Area, had a total of 15 COVID patients in the hospital. And of those 15 patients, only 8 of them were in the ICU. The total for all 9 hospitals that were in the Santa Clara County that serves 2 million people, they had 154 COVID patients and 72 in the ICU. That same date, New York City had 11,739 patients in the ICU. So New York City has around 8 million people. Santa Clara has county has around 2 million people. But the incremental difference was so different, 154 versus 11,000. Updating those data by another week, on April 8th, which is about a week ago, Stanford had only 13 COVID patients and 5 in the ICU. And up to that time, April 8th, 2020, there had only been 2 COVID deaths at Stanford University Hospital. And at that time, they had 54 unused ICU beds. This is in contrast to what's going on in New York City. This is data they present at Grand Rounds in terms of what's going on in the Bay Area, San Francisco versus Los Angeles. These are the number of COVID cases per day. The first COVID death for San Francisco was March 24th, but the number of COVID patients per day is about 30 to 40. Los Angeles COVID death was earlier, in early March, but you can see they're climbing. They're having a number of COVID patients per day in the 500 to 700 range. So we don't know why the San Francisco Bay Area is doing better. The local county health programmers and directors on March 16th shut down the Bay Area, and we're calling it shelter in place, which is 3 days earlier than it did in New York City. But you can see we've been very fortunate for the 2 cases we've had in the San Francisco Bay Area. This is data, these next 2 slides comparing California and New York once again. So this is, as of today, the deaths per day in California. If you look across the graph, it's about 40 deaths per day in California. And the peak is expected to be somewhere around, we're in it right now. It says 2 days till the projected peak. In the state of New York, their solid red line ends at today, and their number of deaths per day, 800. So again, New York is getting hit very, very badly compared to us. You know this, you watch CNN or Fox or whatever you watch. But it's true that scientists don't really know why it is. And some of it is likely due to the fact that people live in closer proximity in New York. They live in high rises, they have to take elevators, they're taking subway trains, and they're walking on Fifth Avenue shoulder to shoulder. Whereas in the Bay Area where I live, people tend to live in houses that are more spread further apart. They drive in cars. But nonetheless, there are probably some sort of factors, perhaps genetic, that makes it such that New York is hit very hard. But the moral of this story is that we are not being hit as hard in the Bay Area whatsoever. The next topic is the fact that so many anesthesiologists in the United States are underemployed right now. when you turn on the TV, you see all this news stories about the horrible things that's going on in the ICUs and the pneumonias, and they're coming into the emergency rooms. But because on March 18th, which is about a month ago, the CMS, which stands for the Center for Medicare and Medicaid Services in the United States, canceled all elective surgery for a month. So that means the predominant number of anesthesiologists are accustomed to going to work and doing anesthetics for people who are having a knee surgery or a gallbladder surgery or open heart surgery. All those things had to be canceled. So ambulatory surgery centers completely shut down. What could you have surgeries for in the last month? Acute infection, acute trauma, if there was a surgery to decide whether you had a malignancy or not, if you had uncontrollable pain, or if the condition had a prognosis such that if you waited till after a month or two went by that the prognosis could be worsened. So for those things, you could have surgery done. But in our group, 95% of our work has been postponed. We had a Zoom call a week ago for the California Society of Anesthesiologists members who live in the San Francisco Bay Area. And only about 5% of the anesthesiologists on the call had taken care of a COVID patient. 95% of them were on the sidelines waiting for anesthesia to happen once again. So what's going to happen after the surge? When are we going to get back to work? So of interest, yesterday, the White House unveiled their plan for opening up America again. And we're all very focused on what's called phase one. Phase one, these are I copied this out of the USA Today coverage in the last 24 hours, but phase one is going to be selected by state governors when their state is ready. And the first criteria is that state has to have for 14 days a decreasing number of COVID cases. So you have to be on the downslope of the curve showing that the surge is over and over for 14 days. And there are other criteria as well. But once this can be affirmed, the governor can say, okay, we're going to open up to phase one. And if you look at what it says under phase one, in this area here, it says elective surgeries can resume on an outpatient basis. And that's very exciting to anesthesiologists around the country, as I told you, because many of us are not working very much. And they would also do these other things. They're not going to be able to test everyone in America. There was speculation over the weeks. Do we have to wait till we can test everybody? Do we have to wait till everybody's antigen negative and or antibody positive? That's not going to happen. But what is going to happen? How are we going to conduct ourselves if we're going to do an anesthetic after the surge? So this slide is taken from a JAMA, that's the Journal of the American Medical Association publication from the end of March, about 2.5 weeks ago. It's a busy slide. I apologize for so much information on there. And what it says at the top, the summary of head and neck examination and procedure recommendations. Well, this isn't only for head and neck surgeons, because this is the area I wanted to focus on, the bottom half of this slide, where it says aerosol generating interventional procedures. It includes the following: intubation and extubation. Therefore, every general anesthetic procedure that requires some sort of an airway tube, orthopedic, ENT, abdominal surgery, almost everything that we do is going to fall under this category in terms of what measures should be taken. And we're going to drop down to the bottom segment where it says low risk to clinician. These are patients who are asymptomatic and untested, or their virus test was negative in the last 48 hours. So we all know that there are asymmetric carriers of this disease. And where we're headed, until there's some vaccine or universal testing frequently, is we're going to have to assume that everybody around us is carrying the virus and they're asymptomatic and you don't want it from them. And that includes our patients. So if you're to go in and do an abdominal surgery, you're going to do a laparoscopic gallbladder anesthetic, and the surge has gone and it's been lifted and we're in phase one, and it says you can do it because it's elective surgery. And maybe that's a poor example because it's supposed to be an outpatient surgery, but we'll say that some places send the laparoscopic gallbladders home. So this is a low risk. They have no symptoms of respiratory disease. And we'll say that it says it's possible there to have a virus test done, but if they don't have it, you're going to assume that they have it. Here's what we're supposed to do, where it says above here, clinical and staff are supposed to wear the N95 mask and eye protection. we're all wearing face shields. We're wearing gowns and wearing double gloves. So these are all different. In February of this year, I was not wearing an N95. I didn't wear glasses. I did not wear a face shield. I did not wear a surgical gown, and I put on one pair of gloves when I handling the airway. So this is what's coming, and I think this is going to be the standard of care for elective surgeries. This is a photograph of myself, wearing all those things. So this is the blue is the N95 mask. The white is the regular surgical mask. We found that if we wear the regular surgical mask over the N95, it keeps it from getting splattered. Some of the outpatient ambulatory surgery centers where we work do not have enough stock of N95 for every individual who goes into an operating room to wear a different mask for every case. So we're looking at least for that day reusing them by covering them up by a standard face mask and this face shield. Another thing that's been suggested, which I have read about and we have not done yet, is the concept of taking a large piece of plastic and covering the entire patient and their airway with the plastic before they go to sleep. Now, or you could put the plastic on after they get anesthesia induced. Or to have the patients wear a mask, just a simple mask to keep them from coughing or breathing on operating room personnel. Once they're induced and they fall asleep, one could put the plastic sheet over them, assuming you have one. It doesn't have anything special, just to be something that's occlusive. And then if the anesthesiologist works underneath the sheet, I've also seen some case reports on the internet where people would just cut a slit in the sheet and manage the airway, put the tube in through the slit. It protects more people in the operating room from being exposed to the aerosolization of the virus. At Stanford University Hospital, a couple of weeks ago, they started a practice when it was time to induce the patient, everybody left the operating room except for the anesthesiologist. And the anesthesiologist would induce, put the tube in, secure the airway, make sure there was no aerosolization going on. If there were airway difficulties and you needed cricot pressure or you needed somebody to come in, then there would be the individuals would be right outside the door and you have to bring them in. But that's something else that's coming. So I think that's the update. In summary, what I want to impress upon you is that it's a very fluid situation, changing day by day. That some anesthesiologists have very dangerous jobs working in ICUs with very, very sick COVID patients right next to the nuclear reactor. And many, many anesthesiologists are sitting, waiting, watching articles in Zoom, trying to wait till they can get back in there and take care of patients for elective surgery. Stay tuned for updates as the weeks go on. Thank you, John.
Well, wow, Rick, yeah, there's a lot of things you said. Because, well, anesthesiologists are no stranger to sterile technique and staying clean and dry. It's not as if, I think for most other doctors, it's quite an exercise to stay sterile, essentially. So that's not a big game changer for you, but it's certainly not working is a big game changer. Now, go ahead.
Quick answer. Anesthesiologists, we've never had to be sterile. Our hands are supposed to be clean and we wear gloves so we don't get secretions on, and we wear masks as we're in an operating room. But the ether screen that's between the patient's face and the general surgeon, orthopedic surgeon is a cutoff between what's sterile and what's just okay.
Oh, okay.
Yeah.
Okay, yeah, maybe that was a different day. They didn't have that, the anesthesiologist was in the field, more or less, and they didn't have that shield. But I guess maybe that's been around a while. Well, when do you think that you'll be getting back to doing elective cases?
This is what I think. The governor of California has put the shelter in place, social distancing in place till May 3rd.
Okay.
So right now it's April 17th. So that's 2+ weeks away. So maybe May is a possibility, but not before May 3rd. The other issue is the phase 1 needing a decline of 14 days in the caseload. And as I said, right now, per CNN this evening when I was watching, they said California has had 3 days. There were a number of states mentioned. Some states had 4 days. There was a collection of about 8 states, so it wasn't very many. If you went by that math, we would need 11+ days. And this again puts us in the ballpark of early May. So perhaps another 2 weeks plus, and we'll be able to do some electives, anesthetics.
Are there some anesthesiologists that think, heck, I'm not going to go back to work for a while until this is all cleared over? and maybe I don't need the money that much, and maybe I'll just wait a year or two. What do you?
Yeah, I haven't heard a lot of those emotions. I have to admit, I have said my prayers for the ICU nurses and the ICU physicians over these weeks, because if I were an ICU nurse in a hotbed like Manhattan, New York City, boy, you know, and I had a family and some kids, and I might think about staying home, because
Right.
is it really worth it to go in there? I think that to the degree the anesthesiologists are going to be affected going forward, I think people are all going to suit up and get in there. It's different, as I said, it's the bimodal distribution. If you were taking care of COVID patients every day, every day, every day, you might just pack it in. But I don't see that as being the future of most people in our specialty. We're going to, the parallels with HIV in the 1980s. I'm old enough that I was giving anesthesia in the 1980s. And actually, I did internal medicine residency and then anesthesia residency at Stanford. And I was an anesthesia resident when the HIV came out. You had to treat everything differently. You always had to wear gloves. And the patient's blood, you had to assume every patient had HIV in their blood. And now we also think everybody has hepatitis B, C in their blood. So we can't go anywhere near anybody's blood. And I think until there's a vaccine and everybody in the world doesn't have it, you're going to see your anesthesiologist dressed up like I showed you in that picture, because we have to assume everybody has the virus that causes COVID-19, because we don't have any way of proving that they don't.
You know, I remember that that period of time, but it certainly doesn't match the hysteria that we have now here, because that was a slow. Remember how we didn't know what was causing that disease back with AIDS. We didn't know what it was. It took a while to isolate the causative organism and etc. But this
it wasn't nearly as communicable. So there were very few of the cases. They were severe, but it was very communicable. And then as we learned more, it was only certain parts of the population we thought could get it. So people were much more relaxed. This is a real difficult, scary virus out there.
Yeah, it's paralyzing all sectors of the society, not just the gay drug users, all society, jobs, everything, from the top down.
Yeah.
You know, I don't want it too much because I'm at the computer all the time anyways, but certainly for someone that's supporting a family, it's totally different. But well, Rick, thank you very much for the education, and we hope to get you back for other anesthesia-related topics. And stick around, we'll chat. Thank you very much.
Thank you. Wow.
Hold on.